I'm going to give you some clinical pearls on how you can work up a patient with adult-acquired flat foot and decide if they need to be braced. They don't all need to be braced. Some of them would benefit from traditional foot orthotic therapy and certainly podorthic intervention. I want to point out that this is not just a rupture of the posterior tibial tendon. We don't call it PTD anymore. We call it the adult-acquired flat foot because we know it's more than just a rupture of a tendon. It's a rupture of key ligaments of the ankle and the hindfoot. It's a rupture of not only the posterior tibial tendon, but the plantar aponeurosis, the spring ligament complex, the superficial deltoid ligament, and often the long and short plantar ligaments. This has been proven in several cadaveric studies and more recently in MR studies showing that these patients have significant ligamentous disruption of their ankle and hindfoot. The challenge to us as clinicians is to figure out if these patients actually have ligamentous rupture or if they're at an early stage where the ligaments are still intact. So what I'm going to do is share with you some simple clinical tests on how to detect that. These are these critical ligaments: the spring ligament, the interosseous talocalcaneal ligament, the superficial deltoid ligament, all get ruptured as the adult-acquired flat foot progresses. We know from cadaveric studies that when ligaments rupture, they mechanically disrupt the function of the foot. They mechanically upset what we call movement coupling between the foot and the leg. Movement coupling is the premise upon which root biomechanics was based, where as the foot pronates, the tibia internally rotates and the femur internally rotates, and this gives the power to the podiatrist who intervenes in the runner with patellofemoral pain, where we can look at the foot and realize if we can correct the foot, we can correct the knee, and we can decrease pain in the runner. This is what gives the podiatrist that magic in the sports medicine community, something that we really need to seize upon and carry further. Movement coupling has been studied extensively over the past 20 years in the biomechanics community. And we found that patients vary in their coupling coefficient, or how efficiently they transfer supination, pronation to tibial rotation. And we have found that when ligaments rupture, it greatly disrupts this mechanism. I'm going to show you a cadaver study I did of various cadaver specimens and the effect of ligamentous rupture on movement coupling. This is a cadaver where we've placed pins on the medial malleolus, the talus, and the navicular. And you can see that as we internally and externally rotate the leg, we have almost perfect transfer of movement between the tibia and the navicular. It's almost a one-to-one transfer. This is a highly efficient foot and leg mechanism. If we cut one ligament, and in this case it's the superficial deltoid ligament, in that same specimen, we now see that the coupling has been disrupted. We're seeing excessive internal and external rotation of the tibia on the left-hand pin, and we're seeing much less motion delivered to the navicular. Beat Hinterman, who has studied this extensively, has shown that interestingly, when we cut the medial ligaments of the ankle joint, which is exactly what happens in the adult-acquired flat foot, we significantly disrupt movement transfer. When you cut the lateral ligaments of the ankle, which is what occurs in an athlete with a lateral ankle sprain, there's almost no effect on movement transfer. And that may be why athletes tend to do well even after they sprain their ankles and function normally. But people who rupture the medial ankle ligaments go on to catastrophic collapse of their foot. Hinterman says this, and I think this is an elegant quote. He says, "These results indicate that the foot becomes partially mechanically disconnected from the tibia by transection of the medial ankle ligaments and even further disconnected after transection of the subtalar interosseous ligament." That's a beautiful phrase, disconnect, where he describes the foot and the leg now separated from each other and not mechanically working together as they do in a healthy person. So we go back and we'll show you again what happens when we cut these ligaments. And you'll see this is an intact specimen, and this is the superficial deltoid ligament being cut in that same specimen. And you can see now the pins do not move in concert. But watch what happens when we cut all the ligaments, including the spring ligament, in that same specimen. That's a spring ligament being pulled away. And you'll see that the head of the talus doesn't move at all. This foot is now disconnected from the leg because of this rupture of those 3 important ligaments. And this is exactly what happens in stage 2 adult acquired flat foot. So we can detect these ligamentous ruptures by doing some simple clinical tests. Some of them are well known to you and some may be new, and I'm going to briefly show these to you. When I evaluate a patient with adult acquired flat foot, I initially bring them out into the clinic and I look at them walk. And before I watch them walk, I look at the patient from behind, because the adult acquired flat foot almost always shows up unilateral. And in this case, it's the patient's left foot, characterized by the too many toes sign, the abducted forefoot on the rear foot. From the front, we look at another patient, and we see the critical sign that I find in every patient with stage 2 deformity, and that's the marked internal rotation of the tibia, or another way to look at it is the anterior displacement of the fibula malleolus. In every case, the symptomatic foot, the fibula malleolus is more anteriorly displaced on the symptomatic side than it is on the asymptomatic side. A simple test for ligament integrity is the Hoopscher maneuver. Many of you know this, where it activates the windlass mechanism. If you have ruptured partially the plantar aponeurosis, which occurs in the adult acquired flat foot, you cannot lift the big toe off the ground and the tibia will not externally rotate. The coupling of the windlass mechanism to the tibia is not just due to the plantar aponeurosis. It requires a healthy arch configuration, most importantly, a healthy spring ligament complex. If you take any patient with adult acquired flat foot of any age, on the contralateral foot, you can elevate the hallux and you'll see the arch raise. But on their affected foot, you cannot lift the hallux off the ground, and the arch will not raise. This is a classic demonstration of ligamentous rupture of not just the plantar aponeurosis, but the spring ligament. Try it in any patient with stage 2 or stage 3 flat foot, and you can't lift the hallux off the ground.